I think I am just going to make sure that I can share everything the way it's supposed to be shared. Which is challenging because I'm not in my usual setup. I'm visiting a friend at Ohio State, so don't tell anyone I work with. If anyone is familiar with our rivalries, we certainly wouldn't want that one to get out. So anyway, all right, so folks should be able to see my screen now. Hopefully you'll find something of interest in these slides that I'm going to show you today. And thank you so much for inviting me and allowing me to join you. It really is an honor to be here. With regard to disclosures, no one gives me money for anything except for the National Institute on Drug Abuse and of course NIAAA. And the work I'll be telling you about today is from the HEAL initiative through NIH. It's a U award funded by NIDA with Maureen Walton as the multiple PI. I just want to start by acknowledging my collaborators. These HEAL grants are huge and they take a huge team of people with many expertise, and we're really fortunate to have such great collaborators both at Michigan and beyond. I think I'm probably preaching to the choir about why we should care about prescription opioid and illicit opioid misuse, but just to give a little bit of context, I'll show you where I tend to be located, which is in Michigan. And you can see our past year NISDA data for pain reliever misuse or prescription opioid misuse. And the top graph is among young people, ages 12 to 17. And then the bottom graph is among ages 18 to 25, or that period of emerging adulthood. You can see we're one of the darkest states, one of the leaders in terms of that for emerging adults. And we generally know about the course of substance use in youth that you're going to see those rates creep up over time as people age. I'm sure y'all know too, heroin use is less prevalent, but still of concern, and just showing you where we fall in Michigan in that space. Now, to tell you a little bit about the work that I'm doing and the study I've been asked to talk about today, I want to give you some background on the need for prevention interventions. A couple of years ago, Maureen Walton and I were working through our CDC-funded U of M Injury Prevention Center and working with the National Safety Council. And we were conducting a scoping review of prescription opioid misuse in adolescents and emerging adults. And it was really looking at articles that have been published in the past 10 years or so that told us anything about risk factors for opioid misuse, the trajectory of opioid misuse, and interventions to prevent opioid misuse in this population. And what we found is there really weren't any great interventions that had been developed with the current context of the opioid epidemic in mind. So a lot of prevention interventions that focused on drug use, of course, were developed many years ago. And there were some that were school-based or community-based that had, some good effects when they followed youth up down the road in emerging adulthood, but none had really been developed during, kind of the current world that we live in now with opioids. And so that we saw as a gap in the literature. And around the same time we were writing this paper, the funding opportunity, the RFA for the HEAL Prevention Initiative came out. And so Maureen and I were steeped in the literature and really saw that this was a great need in the field and decided to apply for one of these HEAL prevention grants. We're one of 9 or 10 sites across the country that received it. And I'll tell you more today about the pilot work that we did during our funded first phase of the trial, which is the UG3 phase. For y'all not familiar with this mechanism, the UG3 phase is a pilot phase, and you have to meet certain milestones that are then approved by NIDA to then move into the full UH3 phase, which is a clinical trial phase, which will also have some other activities as well. So we had a 1-year UG3 period to do this pilot work that I'll say more about today in our results from that. The interventions that we proposed in our HEAL prevention study are based on sort of a body of prior work by members of our addiction center, including a number of people and a body of work that started ever before I became a part of the center as a postdoc in 2011. But I ended up working on all of these studies as a postdoc and as an early career faculty, and really learning a lot. And it's a really great group of people. If anyone ever has a chance to, interact with these folks, I just can't say enough about the talented scientists doing this work. But our interventions are based on a few of these that I'm showing you here. And the first is a brief intervention that was delivered in the emergency department to adults who were at risk for or who were misusing opioids. And this brief motivational intervention showed reductions in opioid risk behavior and opioid misuse, significantly over a control group. Similarly, we had a couple other studies in youth, one in primary care and one in the emergency department, that also looked at brief interventions delivered with motivational interviewing. And these had effects on their main substances that they targeted, alcohol and cannabis, but also had, when we looked at the primary or the secondary data, had some promising effects on prescription drug misuse. So we decided that, this was a viable approach, kind of triangulating these studies. And one of our interventions that I'll be telling you about briefly is a brief intervention. The fourth study that you see down there is a little bit different, but it really set the stage for the other intervention we're doing in our HEAL study. It's a online it functions like a patient portal that Cheryl King developed to do counseling to reduce suicide risk and to increase treatment seeking for suicidality in college students. And I had worked on that study as a clinical supervisor because it was motivational interviewing based. And we really thought there was something to the mechanism of messaging through a portal-like system. And this was work that began prior to, patient portals really emerging as the norm in our healthcare field. And you're seeing here the R34 publication on it. Our R01 results are under review, but that really set the stage for thinking about, well, how do we extend brief interventions, or what kind of other types of interventions that fit within the technologies that healthcare systems have? What could we be using? And we like the idea of using the patient portal. We think that's got great potential for future dissemination. So I'll share more about what those interventions look like shortly. In terms of why we are talking about the emergency department and why our study is set in the emergency department, as a clinical psychologist, I never thought I'd be working with emergency departments. I thought it'd be, an outpatient psych my whole life. But we know that emergency departments have a high amount of visits from people who engage in risk behaviors every year. There's 130 million visits. There are over 20 million for the adolescent young adult age range. It's a setting where we can reach youth at risk. So a lot of times when youth don't go off to college, which about half don't, they also tend to drop out of sort of medical care, regular medical care, as they transition out of pediatric and into adult medicine. And so without a usual source of care, they can often wind up in the emergency department. And that's a place to reach people who may not otherwise be reached. And again, there are, of course, a team of people, including my colleagues, but also folks at other universities that have really led successful ED-initiated interventions for substance use across adolescence and adulthood. The thought's always been too that there's some, sort of teachable moment when you've got a captive audience and someone is in a healthcare setting, concerned about their health, and might be willing to talk about their substance use and focus more on their concerns about their health. So all of our interventions are motivational interviewing based, as I've mentioned. In particular, we use the why-how model of MI, consistent with the 4 processes of MI: engaging, focusing, evoking, and planning. In this approach, exploring why change and how to change are both essential to elicit and sustain behavior change, and are accomplished through the use of MI skills and guided by MI spirit. We historically have used, more face-to-face delivery in MI, but over time we have been incorporating more of the modern methods, some of the technology methods that Jose mentioned. And in this particular study, we are doing remote brief interventions and our patient portal. So our first intervention, our brief intervention, is a brief motivational interviewing based session delivered by a remote health coach. When we initially planned this intervention, this is a pre-COVID plan, we envisioned having staff in an office and the patient in the ED and importing in through an iPad. And this is a model we've used on a few other studies. Post-COVID, our staff and have been at home. We have not gone back to the office since March of 2020. And often we are talking to patients at home. And this is because we had to, in COVID, shut down our in-person recruitment and start cold calling recruitment of patients after they left the ED. So oftentimes everyone is at home, but we ensure privacy. And I can definitely talk about any questions people have about COVID adaptations. I mean, this has been a year and a half of adapting. So now we're doing our session remotely. It's about 45 minutes in length, and again, focused on that why and how change. We follow through sort of a set of tasks or a set of sections in our brief intervention so that it is structured, starting with agenda setting and working our way through different scenarios and risk factors and a summary and plan. It's very tailored or personalized to the individual. As anyone who knows about MI, that's our bread and butter. We meet people where they're at, but we do follow a structure to make sure we cover important topics related to opioid use and also risk factors for use and misuse. Our session is guided by private web-based clinical support screens. That keeps our health coaches on track. And aids in fidelity, that they're not scripted, but there's a guide, almost an outline like one might have for a different type of session. Our portal messaging that I've mentioned, we're doing remote MI-based portal messaging with health coaches with a focus on addressing risk factors and coping. This is a sort of beta version that you're seeing here. Our real version I can't show you because it has participant data in it. But the idea is that we have a dashboard on the left that tells us assessment scores from participants' baseline assessments that tells us about their mental health and substance use. And across the top, we have sort of the quick breakdown of demographic characteristics. And then we message back and forth. It looks very much like any sort of other messaging sort of app. And on the left, we have a memo box where we store, key pieces of clinical content, things we want to come back to. So this mimics a lot of the function that you would see in a medical chart, but we house our portal outside of the medical chart because we have an Epic-based system at U of M, and that would save all the messages as part of a person's electronic health record. And we can't do that for their research messages right now. But the idea is you could do this with sort of any portal system, medical record system, because it's a largely text-based messaging that you can use in any way. And let's see, it's modeled also after the dashboard from the eBridge study, which is a suicide study I was telling you about earlier. So this has sort of been used before in proof of concept. Our portal messaging focuses on a number of different topics. And again, it's tailored to the person. So for example, if they have very few mental health concerns, but they have pain concerns, we might be messaging more about tools and strategies to manage pain and to avoid opioids. For others, depending on what their substance use is, because that's a risk factor for future opioid misuse in this population, we might focus on harm reduction and reducing binge drinking or other substance use. So we can cover a number of different factors that are based on the assessment of the individual and things that are also interest or reported concerns to them. So what we did in the spring 2020 was a pilot trial of these interventions. We enrolled 40 people. They were enrolled February through June 2020. So that was a fun time for lots of us. And they had a 1-month follow-up. We actually enrolled 10 people in the emergency department. And then after the first time we're enrolled, we paused to refine our interventions based on feedback. Like the look and feel of our portal, things that we thought maybe were clunky in our intervention session that we could refine. And when we took that pause, that is when COVID hit and we were shut down. And so then we pivoted to fully remote recruitment and intervention delivery during COVID-19 for the final 75% of the sample. So what happens is we screen people for eligibility for the study. I'll tell you those eligibility criteria in a moment. And then we delivered the health coach session and then portal messaging for 30 days with a follow-up just after. We made a number of adaptations. We had to switch from in-person to remote recruitment and of course get IRB approval for all of that, while everyone else was getting IRB approvals too for changing their research. So it was quite a hectic time. We had to make adjustments for our staff being at home, delivering interventions from home, doing risk assessments from home, technology woes that come with, Zoom and different Wi-Fi issues, the whole thing that I'm sure many of you are aware of in terms of how we've transitioned to the remote world. We had to reprogram a number of surveys to get our consents embedded. We originally gave a screening gift when people would screen in the ER. We couldn't give that anymore. Changed how we delivered payments. And we initially were doing saliva drug screening and mailing the kits at follow-up. And we had many participants who during early COVID did not want to open packages delivered by strangers, especially those delivered to shared mail areas because of their early contamination fears. So we ended up dropping that from the study and the rest of our full RCT with program officer approval. In our pilot, our eligibility, we focused on the age range of interest to the HEAL initiative, which is ages 16 to 30. And people were eligible based on, they could get in the study for one of two paths. One is they reported opioid misuse, either illicit or prescription in the past year. Or in the past year, they reported opioid use, so just medical use as prescribed, plus at least one risk factor for future misuse. And those are other drug use, binge drinking, depression, and suicidality. A lot of that is based on what we found in our scoping review that I referenced earlier. You can see our breakdown generally reflects the demographic breakdown that we see in our ED, although a little bit high on the female side. And we, of course, there are always concerns about generalizability when you start doing a study during a pandemic. So we'll see how these demographics shake out over time in our larger trial. In terms of the criteria that got our 40 people into the study, they were largely those who had prescription opioid use plus a risk factor. Only 18% had opioid misuse and none reported heroin or illicit fentanyl use. You can see that the risk factor that got people who used opioids into the study most was cannabis use, followed by a positive depression screen and binge shrinking. So I wanted to share the feasibility and acceptability data from this trial where we, and since we did these two different recruitment approaches, I break some of it out by recruitment approach just to show sort of what may be the same and different during COVID or in the future for comparison. Our eligibility rates upon screening were similar between the in-person screen and the remote screened, 15 to 17%. The agreement or consent rate really differed. When we recruit people in person, we get a high consent rate among baseline eligibles. When you recruit remote by cold calling, you don't always get everyone. And I think this rate is quite good actually for cold calling random ED patients during a pandemic. So to enroll 56% of those eligible, we were quite proud of. In terms of our health coach session completion, we had high completion. And in terms of engagement and messaging us back in our portal, our remote group was higher. However, we did make changes between this in-person and remote group. And it could be because we did things like add a remember me feature so people's logins could be easier to get into the site later. We didn't have that for the in-person cohort. We made the look and feel better. It could also be that this later group was more motivated or bored during COVID, so messaged us more. We won't ever probably know the answer to that. But because of that low 60% engagement rate in our portal, defined as sending us a message back to messages we were sending, we decided in our last 30 participants recruited remotely that we might pilot an incentive plan for our participants to see if incentivizing participation might result in greater engagement. And this is based on another study that Maureen and I have that used an incentivized strategy to encourage participation. So breaking it up into the four groups of 10 people, the first being this in-person cohort where 60% replied and there was an average of 3 messages per person received, compared to a remote group that received no incentive and 100% replied after we made these changes to look and feel of our portal, and they had an average of 11 replies to us. We also piloted giving $1 per message up to $20 over the month period, and 80% replied with an average of 10 messages. And then we piloted a $5 per message up to $20 total, 100% replied with a mean of 15 messages. So for our randomized controlled trial that's currently underway, given that we were able to get quite a bit of interaction, much greater than we did in the first in-person cohort with the non-incentivized strategy, we decided to go with that because that would be more disseminable later. Health systems might not want to incentivize people to send them messages in the portal. So we went with a no incentive strategy given the rate of replies. In terms of feasibility of follow-up, our rates were high for 1 month follow-up and not that different across cohorts. And then in terms of acceptability, this is on a 10-point scale of health coach session satisfaction. You can see was hanging out around 9 on average out of 10. And our portal satisfaction and our portal would they recommend it to a friend, was hanging out in the high 8s to 9 range. So people generally found that these interventions, were interesting or satisfying to them, definitely weren't horrible to them. So looking at fidelity to motivational interviewing in our sessions, we coded 20% of our health coach sessions. These are bachelor's level health coaches that had MI training. And so they met and exceeded all of the fair thresholds for the mighty 4.2. And on 3 out of 4 of these, they met and exceeded the good threshold. So they were doing really quite well for the amount of training and the level of training in terms of MI fidelity in such a short training period and time to pivot, I guess, during the pandemic. For our portal, we adapt the MI and we code some of the text exchanges as opposed to adding in sort of the relational pieces. That's because more than one therapist we can have interacting in a portal with a participant. So we just focus on the behavioral counts and we have a high fidelity to the behaviors that you'd want to see in motivational interviewing. So overall, we were quite pleased with this pilot, and we were able to receive funding to and have met our milestones and receive funding to a larger UH3 size trial. That is going to and is in progress as of January. It will be a fully crossed factorial RCT where our conditions, our 2 interventions are combined and separate, and we have an enhanced usual care control condition. Our target N is 1170. We have 152 enrolled as of last week, and we follow up at 3, 6, and 12 months. Also, as part of the HEAL initiative, we have planned implementation activities and cost analyses in year 5. And we have done a variety of activities with the larger HEAL Prevention Consortium around harmonizing measures and harmonizing how we'll assess cost and many things. And it's been quite an adventure to kind of learn how everyone's doing it at different sites and really get to learn from our colleagues and see the really cool research that's going on as part of the HEAL initiative. And with that, that was my last sort of planned thing to say, but I don't know if there's time for questions. I think that might have been planned, and I'd be happy to take any, and really thank you for your time.
Yes, we have half an hour left, and we have plenty of time for questions. And I wasn't entirely clear. Let me start with a question. The portal, the portal intervention doesn't have a human code. It's just messages. Help me understand the intervention.
Sure, I'd love to. I feel like you can never do it justice when you're when you have 20 minutes to talk. So our portal intervention is delivered by trained health coaches who are bachelor's or master's level. And they, after the participant is enrolled, they receive at least 2 messages a week through this portal system from their health coach, targeting opioid use, mental health, their various risk factors that are tailored to the individual based on that assessment. And so we don't have a planned script of messages, but we have a manual of example messages that are MI consistent, that cover a number of topics that we then sort of pick and choose and modify and send to the participant at least twice a week. So the minimum dose they receive is 2 messages addressing risk factors per week over a 30-day period. Participants respond to us though, 10 or 11 times on average over the 30 days. And when that happens, we also respond. So the dose will actually vary from that minimum dose of 8 messages to, be dependent on the participant and how much they respond. So we are messaging back and forth using MI. We're eliciting coping strategies to manage, again, pain or mental health conditions. We are doing sometimes encouragement for treatment linkage when people are really struggling with substance use or with mental health. So we're taking a holistic approach of addressing all of those things that can influence later opioid misuse through our messaging.
I'd like to open it up for questions. Namita,
hi. Yes. Thank you for that presentation. A follow-up question on that, whether you said that individuals are bachelor's trained and they're trained health coaches. Are they certified coaches, or what exactly is the training that they have to go through to be in this role as a health coach?
Sure. So we should clarify. It's not the certified health coach, but we use the term health coach for our research clinicians because it's more acceptable to young adults. So they don't necessarily want to be signed up to talk with a therapist or a counselor, but we often use the term coach with our younger participants because it's a little bit more something known to them. Oh, a coach, like that's someone who could maybe help guide me in things and isn't going to tell me what to do, or something like that. And so anyway, we focus on we hire mostly bachelor's level, but we have a few recent postmasters folks that are not licensed but in the process, so still early in their career, and we give them a slew of training in motivational interviewing. So I am a motivational interviewing network of trainer, and so I do a lot of the training to get them familiar with MI. We do a lot of training in what is substance use, what are the things we're concerned about, why do we care about opioids, what should we be worried about with opioids with youth. In addition to, our state has a really great motivational interviewing training program online called Improving MI Practices. So there's a series of modules that we have them go through as well. We also do, because anything can come up when you're doing clinical research with 16 to 30-year-olds or any population. So we do weekly supervision of our staff to make sure that there's odd cases, odd topics that a participant might bring up, that we can help them address it. And we have an on-call model where if someone just, for example, we've had people in our portal, mention past child abuse. We have the staff know to come talk to a licensed clinician like myself to help decide, well, what do we need to do about that? How do we respond to that? And we end up providing a lot of tailored resources to people. So to get back to the question about training, it's also study specific training that you would do in any research study, but we train and have them practice our interventions, and they're coded for fidelity before they go into the field and that sort of thing.
How long does it take?
Go ahead, Namita.
That's hard because you're doing it over the course. So what would be intervention specific, right? Because when someone's hired on for this role, they're also doing the 1,000 research trainings that our university requires. But I would say like in a 2-week period, we can get someone trained up pretty well. If we were just focusing on the intervention pieces and not the research compliance, here's all of your, MRI trainings that we have to randomly do online because we are in a health system. So we have to talk about MRI safety. So,
Thank you.
yeah.
And how do you do the supervision? Do you look at recordings?
Mhm.
Can you tell us about that?
Yeah, so in our supervision, we do listen to recordings of our brief interventions, and probably for the clinicians on the phone or on the line who have been supervised before, you're quite familiar with the pain of listening to yourself on tape. So we get people going early on that and recognize that that's what we're going to be doing, that we listen to different sections of the tape, we pause the tape, we say, well, what went well there? What would we do differently? We have the coaches bring us different sections they're concerned about. So we're always listening to different pieces of tape from different clinicians every week. For the portal, what's really sort of great about the supervision for that is it's 24/7. I can go in and look at it anytime I want. So I can sort of keep an eye on things as the clinician on the study. But also we have, with those 8 messages that each person is required to get, the minimum, we have those during this sort of early training period while we're getting people up to speed. We have those run by a supervisor, so we can, give give overview of, how to make this more are you missing things that the person said that you need to be reflecting? So that's our supervision model for the portal. And I just love the written intervention because you can edit yourself. There's so many things as a therapist I've said that I wish I hadn't said the way I said it. So we really get a chance for people to be really thoughtful and make sure their messages are really great and really targeted to the participant and their needs, because they have that chance to edit and get feedback.
Thank you. Anyone wants to ask a question, please unmute yourself, like Laura has just done. She's a great example.
Hello, I'm Laura Chavez. I'm in Columbus also, actually. I'm at Nationwide Children's. So
don't tell them I was here, but
but I was interested to hear a little bit more detail about the portal and how you manage if there was concern about suicidal ideation and how you sort of promptly respond in cases like that.
Yeah. So of course, with anyone who uses a portal maybe for their own healthcare knows there's always a disclaimer, and so and this was even true in the study that we built this off of, which was a study for people at risk of suicide. And so we do have a banner that essentially says, if you're in an immediate crisis, you can't rely on this to get immediate response, and connect with 911, your local. We have our crisis line, and we also have our psychiatric emergency services at U of M. So we, have that disclaimer. It's a banner, it's visible. I think that's really important. We go through that when we're consenting people as well. Like, this is not an emergency. This is not a place for your emergencies. This is a place for support. However, people do sometimes say things in our portal that sort of reflect maybe they're having an increase in risk, right? So no one has come in yet in our portal and said, I'm thinking of killing myself, acutely in the next 2 days, or, that sort of stuff that activates like high alert. But we do have people who, talk about feeling worse, feeling more depressed, feeling more hopeless. Things just aren't going my way. Some of those things that, like, if I were sitting with a person clinically, I would move into assessment mode. And so what we try to do in that, when that messages, and the messages are checked several times a day, we are shifting the portal from 10 to 8. So we're seeing things throughout the day. when there's a case of that, the staff reaches out to a clinical supervisor on call. We have someone on call every day. And we reach out and we look at the message and say, you know, oh, no, this doesn't sound like risk, or no, we should call this person. So what we do is we call the person and we say, you know, this is so-and-so from our study and U of M, and we wanted to make sure we see how you were, check in with you. And then we would go into doing, you know, pretty standard risk assessment. And if someone remotely is in acute distress, we would work with getting them to the ER or connected to a crisis line, sort of as much as we can do from, you know, remotely. And if someone were really at that point, of course, thinking of harming themselves soon, we could always do the safety check, police, but that would be our last, like, that's our last resort, of course. We're going to try to connect them elsewhere. Sometimes people don't respond right away. So we have a protocol to, you know, text and say, we really, you know, want to get a hold of you and see how you're doing. So so we have multiple sort of protocols in place and supervisors on call to help handle those situations. The majority of situations have been mild risk, people endorse, you know, kind of endorsing, you know, passive ideation with no history, and, you know, just sort of like, oh yeah, I think about this sometimes, but no, I'm okay, and I've got all these protective factors. So it's been harder though to do those cases from everyone's homes though, because you're calling from an unknown, from like a study cell phone that's not a University of Michigan number, and so just, you know, it's posed some challenges. Sorry, Jose.
Jamie Turpin, you have a question. Would you like to ask your question? Jamie?
Oh, I see the question in the chat. Is it considered billable through the portal? And I think the current answer is no, but part of our HEAL initiative is we have a reimbursement specialist, and our part of the goal of the HEAL studies is to develop services that can be implemented and can be billed. And so we're starting to next year work more with them around trying to establish codes and advocacy at the level of the states and the insurance companies and everything to be able to do that. Michigan Medicine itself, I'm aware, has some influence on that because we're just such a large health system in our state. And we had planned to start those sort of that process earlier, but then there was this pandemic. And so all of our clinical resources were focused on, I mean, you know, those things. So we were basically told, don't bother anyone for a while. We're dealing, and there was a period where we were talking about field hospitals and everything. So we're on hold a little bit, but that would be the direction we would want to go.
So would you try to get this as telehealth, or would you try to get your specific evidence-based intervention as a code?
I would hope that it could be more broad and be telehealth, right? Because I think that would open the door for other similar types of interventions. It shouldn't be just us. You know, that I think in the future, we're going to see more and more therapy like this, and it shouldn't just be one specific intervention, but I think it's a form of telehealth.
In many states, telehealth is already reimbursable.
Yeah, but I'm not sure the written messaging part, right?
Right.
Yeah. So our brief intervention, I think, would be already billable under, you know, your typical SBIRT codes, but it's the telehealth, or it's the portal messaging later that is what we would want to change, hopefully, assuming this becomes, you know, evidence-based, it shows effects. We would hope it does, but we never know.
I have a question. You know, in a way, what you're trying to do is sell the patients, or individuals, to not use drugs. It's an idea. In a way, it's sort of, there's a bit of salesmanship. I wonder if anybody's, and there's a whole thing about marketing in business schools, you know, how you market, how you sell your product, how do you get people to buy it? Like the Marlboro Man was a really simple message, but they couched in a way that made billions of dollars for Philip Morris. I wonder if anybody's looked at that, those technologies or informations that are probably taught in business schools about how to sell a simple idea to a lot of people.
You know, I think that's fascinating. So first of all, as a girl from Kentucky who grew up on a tobacco farm, and Joe Camel was part of my childhood, I
Right.
definitely know what you're talking about, especially when it comes to, so how do you instead of marketing the substance, how do you market the non-substance,
Yeah,
the other
just the
alternatives?
Just the idea of,
Yeah.
get it
But
across. Be
I
cool.
do-
Whatever,
It would
yeah.
be cool. And I have to say, my personal sort of opinion of marketing is it's all psychology, right? It's all
Right.
about trying to appeal to people and change ideas and behaviors. And I think we started that field. So I think that there could be some great partnership maybe, and there needs to be more partnership between business and health and prevention of substance use
Yeah.
in order to really get ideas out there.
Yeah,
On a
might-
broader scale.
Might be worth looking just to see if there are any ideas there that could be applied to this sort of a thing.
Mhm.
Huh.
Yeah.
So we have Jordan Brzezinski. Would you like to make a comment? You want to mute yourself, Jordan?
I mean, no other comment than what I wrote. That Sarah Becker, she's a clinical psychologist and researcher at Brown University. She has a significant background in marketing and has applied some of what George was talking about to substance use prevention.
Oh, thank you. I didn't see the chat for a minute because I have like multiple monitors. So she's great. So I'd love to be able to connect with her more. That's great.
Yeah. And there's also a comment by Dave Atkinson.
Yeah, just really briefly, I think there's that group, I believe they're called Rescue, which is a group that did a lot of research on how to market the most effective like tobacco prevention message and trying to break it down into different marketing demographics. Because I think it's so critical to remember that the same message that works for the rural teen will not work for the urban teen, the hip hop teen versus the goody two shoes who does their homework and never leaves the house versus, the preppy popular kid. So I think they've done some good work and are worth looking at.
That's great.
Dave, you remember that presentation very well. Those were the groups. And I don't remember what they're called, but I do remember that the approach is called segmented marketing, where they study the profile of different populations, and then they market the intervention in a different way to each one of them.
I think that could be really useful for some of the implementation work as well, right? Because ideally health systems would be delivering this, but then the health system needs to know, how do I get different people to respond or engage?
But that also speaks, Dave's comments also speaks to doing some profiling of the population with which you do the intervention, determine if it's equally effective with the hip hop, the rural, the preppy, the goody two shoes,
Yeah.
5 groups.
Mm.
This group's research identified in substance abuse.
Yeah, and I think the other groups were like the alternative group, and I think the goody two shoes group was perhaps charitably called the mainstream kids. But and I wish they were more mainstream, to be honest, now that I'm older. But yeah, I think that their profiles tended to work well, and they mapped onto a real world experience that I've seen.
And one of the other things, if y'all ever want to hear more in a future meeting, one of our other sort of lines of work is to do interventions via social media. So we have studies on Facebook and Snapchat that are delivering sort of motivational interventions around alcohol and cannabis use. And I think there's also the idea of that when we talk about marketing and profiles, is there are other things that people are using that could be very powerful tools for interventions. I mean, kids are carrying their phones around in their pocket constantly on them. How do we get to them, and getting to them through commonly used platforms to me would be an option. And we have to be sort of found, our health interventions, our prevention intervention have to be found interesting and cool to them on some level, and using things they're already using, I think, is a strategy as well.
I was wondering in the pilot with your 40 cases, do you have any drug use outcome data?
Since it was a pilot feasibility trial, we haven't examined that data, and it would just be pre-post for the 40 people, since there was no control group in it. So we have that, but we just have not looked at it yet. With the heal mechanism, with the UG mechanism, you are moving very rapidly, so you have no time to actually analyze your data.
Yeah, of course.
Yeah.
Any other comments or questions that anyone might have? Laura?
Oh, sorry, I was just asking if there was a citation for the research you were referencing with rescue. Oh, there it is. Thank you.
I'll have to think about what their name is. I'm not sure if it's Rescue. They're all over the web. But I don't remember what they're called. It's not sure it's exactly Rescue, but it's something similar.
Rescue agency, like the website?
No, it's not an agency. It's a research firm, basically. Anyway, I'll try to see if I can find it and send it out, or any of you who remembers and can find it. So Niranjan is saying, what a great presentation, very much enjoyed it. I have to second that. What a great presentation. I very much enjoyed it, really terrific. And there is also a comment from Adrian Aristide that there is now a suicide prevention hotline, 988. Thank you.
Thank you so much. And yes, the 988 is, I'm not sure when it's supposed to go live, but that will be a resource that we'll be giving to our participants. Maybe it did go live this summer.
I did try. Yeah, I dialed it just to see if it actually works, because I'm working on another research study and it is live, and it just it reroutes and connects them to the existing suicide hotline.
Okay.
But it's just a simple 3-digit number that we're utilizing as well.
That is so great. Thank you for letting me know that. Well,
You're welcome.
We're going to be updating our phone numbers to be much shorter.
Well, thank you so much, Erin. This has been a great presentation, and thank you all for joining us. And we look forward to seeing you at our next chat in 2 months. Have a wonderful, wonderful Memorial Day weekend.
Thank you.
Bye now.
Thank you.